Assalamualaikum. My name is Dr. Fahad, and today we will start our topic of trauma, and we will start with the evaluation of trauma. The objective of our presentation is types of trauma, ATS protocol, and signs of urological injury. First of all, brief introduction of trauma. Trauma originates from the Greek word meaning wound. It implies the physical force exerted on a person has led to the physical injury. Epidemiology. Road traffic accidents are the major cause of long-term morbidity and mortality in developing nations. According to WHO, road traffic accident will be the second leading cause of loss of life for world's population. High morbidity will ultimately lead to the loss of income to the society. For genitourinary injury account for 10% of all abdominal trauma, in which kidney is the major part, 84%, rest, bladder and urethra, each 8%. The early diagnosis of trauma is very important to prevent any serious complications. Types of trauma. Broadly, trauma is categorized into three types: blunt trauma, penetrating trauma, and thermal trauma. We will discuss one by one. Blunt trauma. If the force is from the frontal impact, the cause would be automobile collision. The cause will cause bending steering wheel, knee imprint, dashboard injury, bull's eye fracture, and the windscreen. It will lead to the cervical spine fracture, anterior flail chest, myocardial contusion, pneumothorax, traumatic aortic disruption, fracture of the spleen or the liver, posterior fracture or dislocation of hip or knee, head injury, or the facial fracture. If the impact is from the side in automobile collision, the chances of contralateral neck sprain, head injury, cervical spine fracture, lateral flail chest, pneumothorax, traumatic aortic disruption, diaphragmatic rupture, fractured spleen, liver, or kidney depending on the impact, and the fractured pelvis or acetabulum. If the impact is rare from the behind automobile collision, there is chances of cervical spine injury, head injury, soft tissue injury to neck, or ejection from the vehicle. The chances from ejection from the vehicle means prediction of injury pattern, but place patient at greater risk for virtually all injury mechanism. Motor vehicle impact with pedestrian. It will causes head injury, traumatic aortic disruption, abdominal visceral injuries, fractured lower extremities or pelvis, or fall from the height. It will cause head injury, axial spine injury, abdominal visceral injury, fractured pelvis or acetabulum, or bilateral lower limb extremity fracture. If the trauma is penetrating, it will include stab wound. Stab wound, if to the anterior chest, it will cause cardiac tamponade if within the box, hemothorax, pneumothorax, or hemopneumothorax. If the trauma is left thoracoabdominal, it will cause left diaphragm injury to spleen, or hemopneumothorax. If stab wound to the abdomen, it will cause abdominal visceral injury, possible if peritoneal penetration. Gunshot injury is also included in penetrating injury. If to the truncal, it will likelihood to the high injury, and projectile motion of the gunshot wound will retain the projectile within the body. Extremity gunshot will cause neurovascular injury, fracture of the long bones, and compartment syndrome. The third is thermal injury. The thermal burns, it will include circumferential ischium on extremity or chest, occult trauma, electrical burn. Electrical burn will cause cardiac arrhythmias, myonecrosis of the muscles, compartment syndrome, or inhalational injury. It includes carbon monoxide poisoning, upper airway swelling, or pulmonary edema. Now we will discuss ATLS protocol. Our ATLS guidelines has been updated, and it will include, first of all, preparation, then triage, And primary survey will include small c and A, B, C, D, E with immediate resuscitation of patient with life-threatening injuries. It also includes adjuvants to the primary survey with resuscitation. And if not in a tertiary care hospital, consideration for need of patient to the transfer. Then secondary survey, head-to-toe evaluation and patient history. It also includes adjuvants to the secondary survey. Then after secondary survey, continuous post-resuscitation monitoring and re-evaluation. And in the last, definitive care. We will discuss one by one. Preparation. It includes team assembly. All the hospitals managing severe trauma should have a dedicated trauma team, which includes doctor, the RMO from the emergency department, anesthesia team, general surgery, orthopedics, radiologists, and hematologists for immediate labs. The role of trauma team is to apply the principles of ATLS to rapidly identify and treat the life-threatening injuries. If there is mass trauma, we should first categorize the patient into labels: red, yellow, green, and black according to severity. Which one have to be treated first? Red are the immediate emergency patients which need immediate treatment. If they will not be treated, it will lead to the life death of the patient. It includes threat to the limb, life, or organ. Yellow patient which needs after second time emergency, it need to be treatment delayed. It includes significant injury or illness but can tolerate a delay in care. The third is green, which can wait after red and yellow. It includes minimal injury and needs minor treatment, can safely wait for treatment. Also include the black, in which we cannot do anything, so which will label dead or expectant, which we cannot move. Consider them if all the red patients are treated first. Consider and after initial reds are cleared, if resources exist and if do not delay the patient care for yellow, then care for black patients. The primary survey. The aim of to identify and manage the most immediately and life-threatening pathologies. It includes small c, which include catastrophic hemorrhage control, first of all, from any limb. If there is severe bleeding, control that. Then our ABCD protocol. It includes A, airway maintenance with resuscitation of cervical spine mobilization. Restriction of cervical spine motion. B, breathing and ventilation. C, circulation with hemorrhage control. D, disability and assessment of neurological status, also include GCS. E, exposure and environment control. First of all, give at least 10 seconds for the patient to know his status, asking the patient his or her name and asking what has happened. It will provide maximum information. Appropriate response means no major airway compromise, that is ability to speak clearly. Breathing is not severely compromised if patient is talking, ability to generate air movement to permit speech, and level of consciousness, so it's not markedly decreased. First, catastrophic hemorrhage control. Bleeding must be controlled by application of pack and pressure to the limb, by application of tourniquet and hemostatic dressing. Then come the airway maintenance with restriction of cervical spine motion. Patient with decreased level of consciousness or inadequacy of protective reflexes are prone to develop airway obstruction and chances of aspiration. For signs of airway obstruction, we must look inspection of any foreign body in the oral cavity, identify any facial, mandibular, tracheal, laryngeal fracture, and other injuries that can result in airway obstruction. If need, suctioning would be required, or severe head injury. If the patient is able to communicate verbally, the airway is not likely to be immediately jeopardized. For airway, all patients should be considered to have a cervical spine injury until proof negative, and this has to be significant implication for airway management. In this picture, the one person should stabilize the neck if there is no cervical collar, or if there is cervical collar, immediately apply cervical collar. The neck and head should be supported at all times, especially during the lock rolling. For cervical management, we may require airway removal of blood, vomitus, or foreign body by posture or suction. For airway, we must, if decreased, we must apply first jaw thrust or chin lift maneuver, thorough the insertion of oropharyngeal or nasopharyngeal airway. If required, endotracheal tube intubation or establishment of surgical airway, thoracotomy. In the presence of head or facial injuries, the tube should be placed via mouth. Now, second, breathing and ventilation. First of all, inspect for any cyanosis, peripheral and central, and tachypnea. In the neck and chest, we must look jugular venous distension, position of the trachea, any subcutaneous emphysema, and chest wall exertion. Visual inspection is very important of chest, then palpation, percussion, and then auscultation of the chest. Significant injuries of the chest include tension pneumothorax, massive hemothorax, open pneumothorax, tracheal or bronchial injuries. Use pulse oximeter for oxygen saturation. It will also include as adjuvant, and if required, send arterial blood gases sample. In tension pneumothorax, we will find hyporesonant node on percussion on the affected side, and trachea will be deviate towards the opposite side. Neck vein will be distended, and breath sound will be absent. In massive hemothorax, after chest tube insertion, there is more than 1500 ml of blood in a single go, or continued blood loss in the chest tube 200 ml per hour for 3 to 4 hours, or persistent need for blood transfusion. Then see circulation with hemorrhage control. The maintenance of adequate tissue perfusion, especially to the brain, is the primary objective of the circulatory system. Hypovolemia is the most important cause to the blood loss. Now, bleeding could be any external or internal. External source would be direct manual pressure on the wound, then apply tourniquets for massive exsanguination, but there is risk of ischemic injury. When direct pressure is not effective, the patient's life is threatened. The disadvantage of blind clamping is it will lead to the damage to the nerves and vein. If the cause is internal hemorrhage from chest, abdomen, retroperitoneum, pelvis, or long bone, immediate management is required. It will be identified by physical examination and through imaging. This is the classification of shock. We have classified broadly shock into 4 different categories according to blood loss. If the blood loss is less than 750 ml, which is less than 15% of the body weight, it will be classified as class 1 shock or hemorrhage. If the blood loss is around 750 to 150 ml, it includes 15 to 30% of the blood body blood. Class 3 include 1500 to 2000 liter and it includes 30 to 40%. For class 4, more than 2 liter blood loss, which includes 40% of the blood loss. We will find the heart rate will be remain normal in the class 1, less than 100. If the heart rate, the pulse is more than 100, it will be categorized class 2. And similarly, for more than 120, class 3, and more than 140, class 4. BP will start decreasing in the class 3 and class 4. The pulse pressure will also decrease in class 2, 3, and 4. The patient becomes tachypneic. Respiratory rate will increase in class 2, class 3, and class 4. And urine output is very important for resuscitation. If there is class 1, urine output will be more than 30 ml per hour. In class 2, patient has only 20 to 30 ml, class 3 just 15 to 5 ml, and class 4 negligible or no output. Similarly, the requirement in class 1 and class 2, it will replace with crystalloids. In class 3, we will replace along with crystalloid, blood will be required. Also in class 4, crystalloids and blood will be required for resuscitation. In resuscitation, we must require vascular access to large bore peripheral venous catheter, at least 18 gauge. If we have 16 gauge, it will be more benefit. Blood sample for baseline hematologic studies are obtained, which include all female of 15 to 50 childbearing age should do pregnancy test, and blood type and immediate cross-matching of blood. For assessment of shock, we would send blood gases and lactate level. If peripheral IV access is not possible, then apply intraosseous infusion, especially in children. Central venous access or venous cut down. Initial IV fluid therapy, it will include warm crystalloid fluid, bolus of 100 ml, and it should be isotonic solution. If the patient is unresponsive to initial crystalloid therapy, it must give blood. For massive blood transfusion, we have a protocol of 1:1:1. It includes ratio of 1 PEG cell, 1 FFP, and 1 platelet. There is also a role of tranexamic acid in immediate trauma. We would give 1 gram IV over a period of 10 minutes, followed by 1 gram dose after 8 hours. It must be given within 3 hours of initial injury and should be given to all patients with a systolic blood pressure less than 110 millimeter of mercury or pulse more than 110 per minute. The fourth, disability and the assessment of neurological status. We must use Glasgow Coma Scale to assess the level of consciousness. Level of consciousness will be denominated by a mnemonic AU, PU, AVPU. It includes the patient is either alert, verbal stimulus is present, painful stimulus, or the patient is unresponsive. We must check the pupillary size and the pupillary reactivity. In a conscious patient, all limbs should be assessed for the movement and sensation to detect any possible spinal injury. If the patient with a Glasgow score less than 12 should have an aggressive airway management, which include early intubation. If especially the GCS is less than 8, the patient requires intubation. And this will enable controlled ventilation and the ability to focus on circulatory status. This is a Glasgow Coma Scale. It includes eye opening, spontaneous 4. The patient is responsive to sound, it will include 3. If to the pain, 2. If unresponsive, 1. Verbal response, patient is oriented, give 5. Confused, 4. If only words, 3. And is moaning of sounds, then 2. And if unresponsive, 1. If patient is command following, then 6. Is localizing the pain, it will 5. If there is on pain, there is normal flexion, it will be 4. If abnormal flexion, it will be 3. And if there is extension on application of force, it will 2. And last 1. The maximum score is 15 out of 15 and the minimum score is 3 out of 15. For Glasgow Coma Scale, we will categorize its injury for mild if GCS is 13 to 15. Moderate head injury if the patient has a GCS of 9 to 12, and severe injury if GCS is 3 or between 8. E. Exposure and environment control. The patient must be adequately exposed to allow a thorough and systematic clinical examination. The patient must be warm. We must apply warm blankets and external warming devices. It also gives warm intravenous fluid at a temperature of 102 degrees Fahrenheit, equivalent to 39 degrees centigrade, is recommended, and environment should be warm. Log rolling should not occur until pelvis fracture has been radiologically excluded. Now the adjuncts to the primary survey. We can also do continuous ECG monitoring, pulse oximeter, carbon dioxide monitoring in case of inhalational injury, assessment of ventilatory rate, and arterial blood gas sampling. Urinary catheter must be applied to monitor the urine output and for assessment of hematuria. A urinary catheter is contraindicated if during we will find any blood at the external meatus or blood in the scrotum, or on DRE, the prostate cannot be palpated or is high riding. We can also pass NG tubes, nasogastric tubes to decompress the stomach distension and to assess any evidence of blood. We can also send blood lactate levels. In adjuvant, we include X-ray of the chest and the pelvis to rule out any chest injury and pelvic injury. Also include EFAST ultrasound, and diagnostic peritoneal lavage is rapidly performed. It is an invasive procedure but is sensitive for detection of any intraperitoneal hemorrhage. In EFAST, we must perform 4 quadrants. First, Zephyr. It will assess any pericardial fluid. Then, right upper quadrant, it will include Morrison's pouch or any right coastophrenic angle fluid. In left upper quadrant, we will see any spleen trauma or fluid around spleen and kidney. And in the last, suprapubic, to see any fluid around the bladder. This is the diagram in diagnostic peritoneal lavage, which is evident there is intra-abdominal hemorrhage. Now, if we are working in that do not have any tertiary care, so then it is important not to delay transfer to perform any depth diagnostic evaluation. Only undertake testing that enhances the ability to resuscitate, stabilize the patient, and ensure the patient safety. Now, after primary survey, secondary survey should be started. It will include head-to-toe evaluation. Secondary survey does not begin after the primary survey is completed. Secondary survey is detailed systematic head-to-toe examination in order to detect all injuries and enable the planning of definitive care. During secondary survey, all components of primary survey should be repeated and team should be responsive to any new findings. In secondary survey, we will take patient history. It has a mnemonic of AMPIL. Ask about any allergies to the patient, any past medications, any past medical history, and also it includes pregnancy, last meal he or she has taken, and the event, what has happened during the injury. History may need to be gathered from the family members or ambulance services if the patient is unconscious. Adjuncts to the secondary survey, it includes additional X-ray examination of the spine and extremities, CT scan of the head, chest, abdomen, and spine, contrast urography if suspecting any urological trauma, angiography, transesophageal ultrasound, bronchoscopy, or esophagoscopy. After secondary survey, we must continue post-resuscitation monitoring and re-evaluate the patient. For continuous monitoring, we must check vitals, oxygen saturation, and urine output. For patient, we must relieve his or her pain and give tetanus prophylaxis and antibiotics. The definitive care. Definitive care is all trauma patient needs to be directed by the trauma surgeon or the trauma team. Definitive care include specific investigation if required, the CT scan of the head, chest, consultation with neurosurgeon, orthopedic surgeon, vascular surgeon, document any injury and treat them, specific management plan from all appropriate teams, definitive placement to appropriate specialty team. This is a brief summary of emergency trauma. It includes airway, B, breathing, check for circulation, D, disability, E, examine. It includes primary survey, then secondary survey and adjuvant includes temperature charting, get vitals, head-to-toe assessment, and any intervention if required. Now we will discuss our third topic, signs of any urological injury. If there is large retroperitoneal hematoma, the patient will present in the state of shock, or there may be any palpable mass which may represent a large retroperitoneal hematoma or perhaps any urine extravasation. If retroperitoneum has been torn, free blood may be noted in the peritoneal cavity during EFAST, but may not palpable any mass. For trauma of kidney, we must assess microscopic and gross hematuria. It may cause any tenderness or ecchymosis over the flank region or upper quadrant of the abdomen. Patient with lower rib fracture must think for kidney trauma. Diffuse abdominal tenderness on palpation, and patient can also present with acute abdomen. It will indicate any free blood in the peritoneal cavity. Also, the patient gut sound will be absent and abdomen will be distended. This is the image showing great Turner sign of retroperitoneal hematoma. For ureter injury present with microscopic hematuria, signs of any acute peritonitis may be present if urine has extravasated into the peritoneal cavity or water discharge from the wound, open wound. Trauma of bladder, it will present with heavy bleeding associated with pelvic fracture, may result in hemorrhagic shock, usually from venous disruption of pelvic vessels. And acute abdomen indicate intraperitoneal bladder rupture. A palpable mass in the lower abdomen usually represents a large pelvic hematoma. On DRE, landmarks will be indistinct because of large pelvic hematoma. Trauma of urethra present with blood at the urethral meatus is the single most sign of urethral injury. Patient must have suprapubic tenderness and the presence of pelvic fracture are noted on physical examination. A large developing pelvic hematoma may be palpated. Perineal or suprapubic contusions are often noted. On DRE reveals a large pelvic hematoma with a prostate displaced superiorly. This is the picture showing blood at the meatus. These patients should not be catheterized. Thank you.